question I get so often is about our hormones. How do we test our hormones? And I will say that there's no body fluid that we don't get information from, especially as a gynecologist, from blood, urine, vaginal fluid, stool. I mean, everything tells us a story. And beyond that, our symptoms. And with that said, I will say treat the patient, not the labs. But it's important to understand what our hormones are doing, how they're metabolized, and hormone metabolite testing is a key area. Welcome back to the Girlfriend Doctor Show. I'm Dr. Anna Cabeca. I am the girlfriend doctor. I've been studying hormones for over 30 years, and I look forward to having this discussion with you today and our guest, who is an expert in hormone metabolite testing and analysis, as well as intervention and treatment. So today I want to introduce you to Dr. Liz Bartman. She is a naturopathic doctor with 2 decades worth of experience in the medical field, and a little over 10 years of that time spent in functional and naturopathic medicine. She graduated with a Bachelor of Science degree in cellular and molecular biology. This was followed by several years working in the nursing and research field before deciding to go into naturopathic medicine. She holds several advanced certificates in herbal medicine, environmental medicine, and genetic and genomic nutrition, and that this allows her to hold a unique perspective on both the science and wisdom of natural supplementation and precision medicine. She currently serves as the Director of Clinical Sciences for EndoAxis, where she marries complex hormone analysis with a systematic approach to identify the root cause of a hormone imbalance, partnered with robust herbal formulations created to target the why and not the what of a hormone concern. She enjoys bringing the gaps of treatment and research in both the conventional and functional fields to provide tailored, evidence based therapies to patients and providers. This will be an in depth discussion. We're going to get into the science and understanding hormone metabolites. And it's important, if you've never had hormone metabolite testing, that you do get it done. And by the end of this conversation, you will understand why and also what that could mean for you, your health and longevity, and optimizing your overall wellness. And we want you to feel happy and healthy in a body that you love. So join me in welcoming to the Girlfriend Doctor Show, Dr. Liz Bartman. Hello, Liz. Welcome to the Girlfriend Doctor Show. It's good to have you here.
Thank you so much, Dr. Anna Cabeca. You are such an inspiration to me. I'm so excited to be here.
Oh my gosh, you blew my mind when I heard you speak at the microbiome conference in Monterey last year. And I was like, oh, wow, you have dug into the science, the research, let's just say the nitty gritty.
Absolutely.
And
Yes.
and when it comes to, hormone testing, what do you like when people say, okay, well, what should I test? How should I test? What is your response?
So, when you're looking at the full story, right, you want to see how are hormones not just circulating in the body, but actually behaving at a cellular level. So, when I test hormones and when I encourage others to test, it's really a blend of both looking at your blood or saliva to see more the fraction of what's in circulation and pair that with urinary evaluation as well. That urine really gives you an unfolding of a story you miss with the other two methods of testing.
So when we think of that, okay, so what's the blood telling us versus the saliva versus the urine?
So, serum testing or the blood is really showing you the protein bound fraction. There's ways to calculate the free fraction, but you have to remember that our sex hormones are fat. And so they really don't circulate in a medium like blood, which is mostly water, very easily. So it has to be circulated via protein bound kind of chaperone, which we call sex hormone binding globulin, as well as albumin. So that's going to be circulating around our sex hormones outside of the tissues that are actually generating and utilizing them. And so when you're looking at the blood, you're really just capturing number one, what was in circulation at that single point in time during that single day, if you're a cycling female, during your cycle. If you're not cycling, just during that day and time. If you're a male, then it's just during that day and time that has more diurnal fluctuation, but again, a single point. And again, that chaperoned portion. When you look at saliva, you're looking at what's passing through the cell. So because the sex hormones are lipid based, they are fat, and our cells are a lipo molecule, so they are fat lined. sex hormones can passively diffuse right into those cells. So in saliva, you can see that passive diffusion, what's captured within the tissue. So what would be considered the free fraction, what can pass into the cell and get used by the tissue. Now in urine, you're looking at truly bioavailable hormone. So it's not just what passed through the tissue, but it's what was utilized at the receptor level. So what is capable of binding to hormone receptors? And then uniquely, how did the body break it down? So what did the body do? What did the cells do with that hormone once it bound to a receptor? Did it metabolize into optimal metabolites that just easily excrete out into urine, have no other kind of activity in the body? Or is it metabolizing in a way that could actually prolong the life of that hormone and increase the response that you're getting from that hormone for better or for worse?
So it's important to understand, like, each body fluid tells us something different,
Absolutely.
right? And it's like,
Yeah.
it's good to look over time at different mechanisms, these different presentations of our hormones, because what we're seeing in the blood, we might not see in the saliva or the urine, right? And
Yeah. They all
also,
capture a different view. Mhm.
yeah, and I want to talk specifically about the postmenopausal woman's hormones because, okay, we've got these postmenopausal hormones and we expect them to be low on the low side, but still how they're metabolizing makes a difference, right? And then if
Absolutely.
we're optimizing hormones with hormonal therapy, how we're taking those hormones is going to show up in different ways.
Yeah,
Can you speak
absolutely.
to that?
So the way you take, so yes, when you think about the factories in our body that are producing sex hormones, and for women, the ovaries are the champion. They're the primary factory producing the majority of estrogen and progesterone during our lifespan. But unfortunately, we go through menopause and our ovaries no longer have any follicles. That's the definition of menopause. It's saying there's no more eggs left. So now that factory shuts down, right? The ovaries go offline. So we lose 2/3 of our estrogen, right? We drop significantly and we lose the majority of our progesterone because although the adrenals produce a little progesterone, it's not nearly what you make from the corpus luteum, that little transient endocrine tissue that's made after you release an egg. So you've just declined significantly, right, in this very short period of time in how much hormone you produce. And it really is the adrenals that have to take over, in addition to adipose. Right. So fat tissue is its own endocrine gland. And one of the unique and kind of fascinating things to me is that, as we're going through our perimenopausal transition, there's the signal from the brain that's, I call it a knock on the door. It's kind of saying, hey, ovaries, you got any eggs left? Let's ramp up production this month. And that signal is called FSH, right? Follicle stimulating hormone. And so that's knocking on the door of the factory of the ovary. And if the ovary is like, oh yeah, I think we have some eggs left, let's pull some out, right? Then you might start to develop that follicle. But in that perimenopausal window, you may be having to dig a lot deeper in the factory to find the reserve, right? It's like, there might be some in the back room, let me check, right? So it takes a little longer to get to that kind of final maturation of an egg and release. And that's where cycles start to fluctuate in length. Well, what's happening is FSH is knocking louder and louder. So you're getting these spikes in FSH. Well, one of the things FSH does outside of knocking on the ovary is it increases this enzyme called aromatase, which is CYP19A1. And aromatase is not just active in the ovary, it's also active in adipose tissue. And so as FSH increases, the adipose is like, oh, hey, we can respond to this too. Now it's at a high enough level that we're going to take this in and increase expression. But what does aromatase do? It's actually taking our androgens, testosterone and DHEA, specifically an intermediate called androstenedione, and it's converting that into estrone. And with testosterone directly into estradiol, but mostly estrone. And so adipose can make a little estrogen for us, right? And that's where we start seeing shifts in our metabolic rate and even in our fat composition as we go through our perimenopausal transition, because the body's trying to kind of prepare us, right, for where our estrogen is going to come from in the coming years. So all of a sudden you get this rapid decline in hormone. Now we're dependent wholly, once you go through that kind of menopausal state, which is a single day, right? It's when the ovaries turn off. And now you're in your postmenopausal transition 12 months after your last menstrual period. All right, now it's the adrenals and the adipose that are really taking over, and they don't really produce a lot of hormone. And so there are consequences to that, right? We start to experience greater climacteric symptoms. So hot flashes, night sweats, vaginal dryness, changes to libido, mood, sleep, again, the weight changes, right? In addition to metabolic changes, we get greater risk. Nitric oxide isn't as robust because estrogens are needed to stimulate nitric oxide synthesis. So blood pressure can start to augment and go up a little bit. Whole host right, of kind of sequelae that happen as that estrogen change, it starts to crumble, right? It's kind of like a domino effect. It's like everything starts to
Right.
drop. So, we can introduce exogenous estrogen, and we can do that in a number of ways. And then we also couple that, because I think of estrogen and progesterone like yin and yang. They have equal and opposite benefit in the body, and we want them together. Technically, if you don't have a uterus, they say you don't need that progesterone piece, but that's
I
not true because
disagree.
there's
Right.
so
No.
much. Yeah. There's so many other neurological reasons you want progesterone. Progesterone supports the bone in a kind of equal and opposite fashion to estrogen. So it's like we always think about estrogen for bone health, and that's true. It is a very important bone builder, but so is progesterone, right? It helps with that matrix. So I do think that there's, outside just protecting the uterus, as you said, so many benefits to having progesterone on board. And again, it's the yin and yang. They're the partners in crime, so to speak. And when we introduce them, you can, there's a whole variety of ways. You can do sublingual, you can do, which is just under the tongue with hormones compounded for you, in specific doses for you and for your levels in response to therapy. You can do topicals, you can do vaginal applications, you can do injections in some cases, and they even have pellets. Of course, there's the oral capsules. I'm not a fan of direct oral because that's going to hit the liver a lot more, but progesterone can be taken orally, and that definitely is one that doesn't impact the liver in the same way. And you get the benefit of the metabolites of progesterone in a slightly different ratio.
To help
From
you
taking
sleep.
oral
So
to
that's
help with
key.
sleep. Yeah, exactly. So, and the way that those represent in our different testing mediums, when you're looking at anything taken in orally, if you're looking at a waste product like urine, you're going to see really high levels if it's taken on the same day of testing because of that first pass, what's called first pass, where it just hits the gut. About 80% gets shunted out of the body, never goes into circulation, never is utilized by the body, is processed by the gut a little. So it does impact the gut. But you're only getting about 20% circulation. And so when you're looking at oral or sublingual dosing of hormones, and you're looking at urine, you're going to see really high levels if taken on the same day, simply because of that waste effect, that dumping. Versus, when you apply topicals and you look at saliva is an intermediate chain in our lymphatic detox. And so I think there's still some unknowns about what saliva is really capturing, but you tend to get overinflated values in saliva with topical hormone. And I think a part of that is because it is kind of in its transition through, it's in the tissues, right? It's present, but we have to ask ourselves, was it present on its way to being removed from the body, or was it present because it was actually utilized by tissues? So kind of teasing it out in a similar way as we tease out oral in urine. So kind of an equal conundrum that we have to look at. And then really with the serum testing or the blood, with all of these routes of administration, you're going to see that protein bound fraction, which again can be a little limiting because it's not always circulated when we take something exogenous from outside the body. It doesn't circulate in the same way necessarily, but the blood is going to be your more validated way to measure response to therapy.
And then the urine, when you're taking oral therapy, we'll just see
Looks
that
really high.
really high over
Yeah, that
abundance. But
dumping effect.
will
Yeah.
it give
But
us
topicals.
Mhm. Will it also, if we're doing it orally and we have this high level, will that show us which pathway it's going down, 4, 16, or 2?
Can be skewed.
It can be
Yeah, you
skewed.
can still see ratios, but they're going to be altered by kind of what's happening at that just kind of first pass response, not necessarily what the tissues used, but really what the liver just processed out. So it's not necessarily true to how your body's utilizing the hormone.
Yeah. And transdermally, though, in the urine, like if we're using transdermal estrogen patch, topical creams, vaginal preparations, how will that show up in the urine?
So that shows
Because
up
we're
really
not gonna
nicely
see
in
it as
tissue.
much in the blood. I mean, we'll see the estrogen patch in the blood. We do see that, um, really clearly, but, um, in the urine, how are we seeing that?
So because the urine is really reflecting that tissue available receptor utilized hormone, you do get a good view of those transdermal applications, even vaginal applications. It shows up really nicely in therapeutic levels within the urine test. Yeah.
And so we can see what's really available for our clients, what they're actually receiving, what they're using. Yeah. Is that true
And
with topical progesterone and DHEA as well?
so topical progesterone is a tricky one. Progesterone has a really short half-life. And it tends to sequester into the tissue it's applied to. So the body really tightly controls and regulates progesterone. You don't see it in urine as well when you apply it topically for that reason, because it just gets sequestered and kind of pulled and eliminated in a more kind of rapid state, and you just don't catch that in the urine. So you don't see, and it doesn't go through the same metabolite clearance. So you're not seeing the end product that we are really primarily looking at with urinary metabolites, the alpha and beta pregnanidiol, which are your primary progesterone end products. So yeah, topical progesterone still likely a benefit, right? We're seeing change at the tissue level. We're seeing therapeutic response. Doesn't catch in urine though,
Yeah,
because
we
of that
definitely
tight
see it in
tissue.
saliva, however,
Yes.
and it
Yeah.
can be really elevated in the saliva. And then again, topical progesterone, not necessarily seeing it in the blood, but like, are we still getting the neurologic benefit? Seems that way because we get the clinical response that we're looking for, but that's the question.
I think there is a dose dependence on that topical progesterone. I think you have to go a little higher with topical progesterone to see the same neurological benefit. And I think part of that is that you're not getting that same circulation to the liver to convert to the allopregnenolone, which is that intermediate of progesterone that can cross the blood-brain barrier and is really the GABA allosteric modulator. So it's kind of, I think of it as like turning the switch up on allowing GABA into a cell, right? It's allowing
Yeah.
that greater utilization. So with topicals, we don't see that same conversion as much because it's not hitting the liver in the same way, and that's really where that conversion occurs at the greatest amount. So I think you do still get the response, but you end up using a lot more topically to
Mhm.
get the response.
And then we think about, okay, how our hormones are created. So we go from cholesterol to pregnenolone and progesterone to cortisol and pregnenolone to DHEA. Can you talk about that? Like when we think cholesterol, right? Cholesterol's been given such a bad name over the years, and we're like, hey, that's a good guy. Where,
It really is
like,
a
is it really is a good guy. So let's talk about that cholesterol. Which part of the cholesterol is making the hormones? Where are we getting this hormone from? And how that process even starts.
Absolutely. Well, so yeah, cholesterol is our building block of all what we call steroid hormones. So any sex hormone, cortisol, DHEA, right? These are going to be our steroidal hormones. They have to be like produced by our body. They're produced in what I call the factories, and the factories are all signals that are created either like, which is all enzymatic, peptide, or protein derived, which is from our DNA. So I always think about that, like far back. The original story is that all of our cells, right, have the entire code of life, and that's our DNA, right? That's the instruction manual, and yet they're coding then those instructions help set kind of the foundation for how we then utilize cholesterol and convert it in various tissues into the downstream whatever we're trying to create, right? But in this case, the downstream steroidal intermediates or hormones themselves, so sex hormones. So when you think about what's happening, so our cholesterol, our liver is making cholesterol. It makes most of the cholesterol. We do consume a little, but it's like around 10% or less that we actually consume. So that's often a misnomer where they're like, oh, stop eating, high cholesterol or high fatty foods because it's going to increase your cholesterol. Well, it really doesn't. We make most of our own cholesterol, right? Like doesn't work the same
That's a
way.
great point. Yes.
Yeah. Unless you have familial hypercholesterolemia, which, you do absorb a lot more from diet, but that's a very, very small fraction of people. So our liver is making our cholesterol for us. It's the LDL that we actually convert, and it's this enzyme within our gonadal tissue, which are gamete producing tissues. So the testes or the ovaries, or the adrenal glands, right? And so there's an enzyme called STAR, and it takes that cholesterol and it pulls it into the mitochondria of those tissues. And the mitochondria convert into pregnenolone. So that's all in the mitochondria. So it's very specific to cell type. And I like to emphasize that because the idea of like the progesterone or pregnenolone steal is a little incorrect. The same thing is happening to suppress progesterone from like we do see a suppression under high stress of ovarian progesterone and higher cortisol synthesis, but it's not because the adrenals are stealing, right, the progesterone from the ovary. It's really that the stress signals are downregulating FSH and LH, saying, hey, we're under a lot of stress right now. We can't support ovulation this cycle. We're going to lower synthesis here, while at the same time, we're going to be driving up cortisol to make sure we can escape from this danger that we are under right now.
So that's the
So it
question,
is,
because like we're making cortisol from progesterone. We're producing cortisol. It's, it's backing up and saying, okay, we're going to suppress hormone production. So we're going to suppress that progesterone production, pregnenolone production too, and hence testosterone and estrogen. Is that correct?
well, so what's happening under high stress is the adrenals are going to receive a lot of ACTH from the brain, right? So the brain is saying, well, we're getting this high stress response. The brain's knock to the adrenals is ACTH. It's like, knock, knock, kick out cortisol. So in the adrenal tissue, you're going to favor cortisol preference, but that's not where the bulk of your progesterone comes from, right? Progesterone, tiny little amount from the adrenal tissue, and different regions, different zones, right? So you have very specific regional tissue within the adrenal cortex. So the zona fasciculata is going to be making your cortisol. The zona reticularis is making DHEA. The zona glomerulosa is then making aldosterone. So you have your three subsets that all have their own unique mitochondria, right? And so it's really that cholesterol is just getting shunted and favored into the right tissue for the right utilization. It's not that it's getting stolen per se, but then that cortisol, once that surges, it's telling the brain again, hey, we're under a lot of stress right now. So then the pituitary says, okay, we're going to downregulate now that response to the FSH, LH that are going to the other tissue, to the ovaries. And we're going to say, let's suppress ovulation this cycle, because if we're under this much stress, we don't want to necessarily conceive a child as well, right? Like there's this like innate feedback loop that's protecting us. It's ensuring survival of the species. So that's like a subset, but it's just to say like tissues can't steal from each other, but the signals that happen can direct resources to other tissues. So the priority becomes the adrenal tissue at that point under high stress, that then generates a lot more cortisol, and you see that decline in progesterone, not because it's stealing it, but because the priority is going to be on cortisol over reproduction.
So, but still cortisol is made from the progesterone. So we're
It's
derived
made from pregnenolone,
from
right? So it has,
pregnenolone. And then pregnenolone, DHEA is made from pregnenolone.
everything is, yeah. Pregnenolone is your master hormone. Yeah. And those hormones, though, are made outside the mitochondria. So in our tissues, so we bring in cholesterol, we bring it into the mitochondria, we convert into pregnenolone, and then that pregnenolone can come into the endoplasmic reticulum, which is like the little factory center, like for transformation within the cells. So it's taking this master package and saying, okay, what next? Where does this need to go? And that's when you start upregulating enzymes like CYP17A1, which is going to convert it into that androstenedione, which is an intermediate of DHEA, to testosterone. And then testosterone can aromatize into estrogen. But that happens very rapidly in the ovary. So all estrogen actually does start as testosterone. I always like to remind providers of that one too, because I think sometimes that gets forgotten, but that's kind of one of your, like, I don't want to call it a broken enzyme, but that's one of the dysfunctions that can occur that increase risk for PCOS, as an example. So when PCOS is that polycystic ovarian syndrome.
Yeah. When the testosterone's not aromatizing?
Correct. Yeah. So CYP19A1 is downregulated in its expression. For one reason or another, there are polymorphisms that are associated with that risk as well, but it can be environmental. And then that just puts that preference, instead of testosterone aromatizing quickly over to estrogen, it gets stuck. And then you just make a lot of testosterone.
Testosterone, or converting it to dihydrotestosterone.
Exactly. Yeah.
Yeah, depending on 5-alpha reductase enzyme.
Yep. It's how complex it gets, and how you can see so much of this with urine, right? Because you're going to see all of those intermediates kind of along the path, and really kind of piece together the story of what's happening at that cellular level, which is very exciting.
Yeah, and it's also baffling. It really is so baffling. It's the concept of, okay, when we're looking at urinary testing, and I've just reviewed thousands of tests, I've been through my career of urinary metabolite testing, and one of the things I learned early on was the importance of the estrogen detoxification pathways, the 2, 4, and 16 estrogen detoxification and methylation pathways, and to be able to look at that. Now, before we used to say a low 2 to 16 ratio was a risk factor for breast cancer. What's the latest science on actually these ratios, the 2 to 4, 2 to 16 hydroxyestrone ratios to breast cancer? How much should we be concerned? What's the situation on that?
So there are concerns with those intermediates. 16-hydroxyestrone is a tissue proliferator. So it can go back. So we think about estrogen, estradiol, and estrone passing into our cells and binding to an estrogen receptor. It forms a little estrogen receptor complex that then enters into the nucleus and tells the DNA, hey, we need to increase expression of whatever it may be for that cell type. I'm going to use the example of the uterus just because that's an easy one. It's like, let's increase proliferation, right, of the uterine lining to help prepare for potential implantation. So if that's happening, right, then that estrogen starts to break down and metabolize. And one of its metabolites, if CYP3A4, which is one of our CYP450 hydroxylation family of enzymes. So these are basically taking fat intermediate or fat hormones and saying, okay, we need to make this into a water soluble intermediate so that we can start to eliminate it from our body. So it's adding a hydroxyl, it's adding a little water subchain essentially. And for that initial conversion, well, there's CYP3A4 that will take that estrogen, that estrone and estradiol. It'll take estrone and convert it into 16-hydroxy-E1. And it takes estradiol and converts it to estriol. Estriol, pretty benign as an intermediate. 16-OHE1, however, can recirculate and bind to estrogen receptors once more. So now you've had estrone hit the receptor, it's converted into 16-hydroxy and it hits it again. It's a weaker bind, but it is increasing that proliferation potential. So instead of growing, let's say 1 block, now we've grown 2 blocks, right, of estrogen, if we think of them as like little bricks lining the uterine lining. Mm-hmm. The same would go for breast tissue. We're proliferating that breast tissue a little more. Now, is it causing a tumor? No, but it will cause a tumor that's present to grow more rapidly. That's the concern with 16-hydroxy-E1. So it's not the risk that it's causing cancer, but that if cancer is there, it can cause it to grow a little more quickly. And we see that with both breast cancer, we see that with endometrial cancer as well. And so there is that proliferation, but it's not all bad, right? 16-hydroxy-E1 is also bone protective. And when we lose our estrogens in that menopausal transition, it's 16-OHE1 that has a little residual like bone support, right? As we've lost our estrogens. So there is some benefit to having it around as well. We just want to make sure that we're reducing oxidative stress and protecting our DNA from adduct formation. And that's where 4-hydroxy comes in. So 4-hydroxyestrogene, and we can have 4-hydroxyestrone or 4-hydroxyestradiol. These are intermediates of estrogen through that same CYP450 family of enzymes, converting and adding basically through the CYP1B1, a hydroxyl group, to a subchain on estrogen that makes it a little more reactive and unstable. So basically now that intermediate, that 4-hydroxyestrone or 4-hydroxyestradiol can, if they don't get methylated, can get transformed into what's called a quinone. So there's this quinone pathway.
What is a quinone? It sounds like quinine. It sounds like quinine, right? Like that.
It's an oxidative stress. It's a free radical. Exactly. It's not good. Just like quinine is not good.
Quinine is not good. Quinone is not good.
It is not good. And it can enter into the nucleus. And again, it damages DNA. It creates what are called adducts, which I think of as little speed bumps, right? And the more speed bumps you have, the more error you're going to have in replicating that cell. The more error you have, the greater the risk that that cell becomes kind of rogue, right? And that's kind of the defining feature of the initial kind of that initiation of a cancer cell. So it not regulating itself any longer, even though it's damaged, and then propagating itself in a damaged state. So we really want to reduce those quinones. And 4-hydroxy with those unstable adducts can be a big concern. And we do know that is the one that does increase that cancer risk a bit. And so you can look at those metabolites, you can look at those
Because it's
ratios
damaging. It's actually
because it's
damaging the
damaging the
tissue. It's
DNA.
oxidate. It's called it creating oxidative damage, right?
It is. Yep, it's creating that oxidative stress specifically to DNA, and how the cell then can replicate itself. And there are genes that are associated with protection or not that would increase risk if 4-hydroxy is high. So we think about NQ01. This is NADPH quinone or NADPH oxoreductase. So it is one that's a mouthful, but it is in our phospholipid bilayer of every cell. I think of it as a sentry. It's kind of like the guardians of our cells, and it gets triggered by quinones. It's that quinone oxoreductase. So it's taking those quinones and saying, okay, let's neutralize you and get you out before you cause massive damage to this cell. Part of what it also does is turn on P53, which is a regulator of cell replication. It says, okay, if we're damaged, we're going to turn off and we're going to start anew and make sure that we don't pass or propagate this damage onto future cell lines. It also upregulates or increases expression of active tocotrienols from vitamin E and CoQ10 conversion into active ubiquinol. So it's really this master kind of free radical. I think of them as like little Pac-Man going into the cell and eating up all those free radicals.
NAD. NAD is.
So the NADPH quinone oxoreductase enzyme.
Okay.
Yeah,
Okay, that enzyme is that Pac-Man.
Is that Pac-Man. Yeah.
So it upregulates P53, like progesterone upregulates P53. So increasing apoptosis or natural cell death or turnoff. So NADPH, so if they have an impaired pathway to that, and it was the NQ1, like,
yeah, NQ01. Yep.
NQ01, if they have a genetic SNP that's affected, they're more likely to have an elevated 4-hydroxyestrone. Or
they're more likely to have quinone damage at a greater extent from 4-hydroxyestrone. Yeah, so the risk of 4-hydroxy being high in tandem with a SNP in that NQ01 gene is going to increase the risk for oxidative burden and potential for DNA damage.
So where can we see that? Like, how do we know when we see an elevated 4-OH or even in the normal range of 4-OH, 4-hydroxy? Actually, let's go through a Dutch test. Let's go through a urinary hormone metabolite testing test, and I'll share a couple. And when we go through this, so if you guys are listening, I'll talk through it so you can visualize as we go. But otherwise, hop over to my YouTube channel at The Girlfriend Doctor and watch this video. It's important to understand what's happening here and to give you that good information and understanding from my expert here. It's amazing. Here we go, sharing this hormone test. So we look at this client not on hormones, in her 50s, and we see this initial hormone testing summary. And we're like, okay, red flags all over the place. When you see this, I would love for you to walk through, like, okay, I see that this is what my analysis is.
Well, just from the snapshot, right? This is going to give you your high level, what I call the parent hormone overview. So these are the primary hormones that are going to be acting at the cell level on those receptors. So we have estradiol, your most active estrogen. We have progesterone there in the middle. And when you're looking at the dials, you have those 2 gold stars and that green band. And I like to call these like the gas gauges. In a cycling female, we're going to see that's the luteal range. So we're going to see a level if your ovarian response was active and you had made a follicle and we're developing that uterine tissue in that luteal phase, you're going to see this nice wave of estrogen occur that should fall within those 2 gold stars and really kind of within the middle.
Because typically we're going to look at day 21 on a menstruating individual.
Yes, absolutely. Because that's going to be the day that if they ovulated, progesterone will also be around its peak for the month. So progesterone we only make for about 12 to 14 days per cycle, and it only occurs after the successful release and rupture of a follicle. That's when you create that little fatty body called the corpus luteum, which in Latin is yellow body, because it's full of like good fatty antioxidants. And it's that progesterone factory. That's its primary role, is to make progesterone to help in potential conception. And so you can see if progesterone was elevated as well, or we would expect that if a follicle had ruptured and that corpus luteum had been created. And your levels are both pretty low. Your progesterone's actually, so that purple band at the very far left, that little tiny purple, that's where we expect a postmenopausal level of estrogen and progesterone. So if the ovaries were contributing nothing to the hormonal synthesis, we'd see kind of that purple band. And you're above the purple band on progesterone, which makes me wonder if you were either utilizing a topical progesterone or maybe an oral at the late set. Pregnenolone would also convert into those metabolites, or stress.
Stress, right? Yeah, because we should even the postmenopausal range, we expect it to be low, and this is a few years ago, but definitely at high stress time as exhibited by the cortisol pattern.
By your
But
cortisol, yeah, absolutely.
yeah, that, some probably topical progesterone seeping through there and pregnenolone.
You'll capture a little topical in urine, especially depending on dose. But yeah, stress, right? Because the bulk of progesterone really is coming from the ovaries, but you do make a little from the adrenals as well.
Mm-hmm.
We do see that go up in those kind of stress states when the ACTH is knocking on that cortex. And then testosterone's next to you too.
This is the thing when we look at that purple range, while it's normal, it's not optimal.
Correct. Yes, that's a great point as well. Yeah, but although it's expected, it doesn't feel good.
No.
Yeah, it comes with all host of other negative sequelae for sure.
Right.
It's definitely one we want to address. It's just one that we're not going to get the ovaries to kick out for us any longer, right? We can't recruit their help anymore, unfortunately. But now testosterone in women, testosterone comes primarily through peripheral activity from DHEA conversion and adipose, which is really fascinating. So you do get some testosterone and more so depending on your enzymatic glitches or errors, right, in the ovary, but you actually make more peripherally, which is why testosterone becomes more of a primary hormone in our postmenopausal years. And you can see there is that, again, those two gold stars. There is an age dependent or ideal range as well. We know testosterone and DHEA tend to peak for both men and women in our 20s with a steady decline of around 1% to 2% each year after around age 30 or so, depending on stress and nutrition and like movement and genes. But you can see that your level, although kind of on the lower end of the gauge, you are within what we would call like an age expected range, which again, age expected, but maybe not ideal. We tend to like to get levels of androgens where you were in your 30s before that decline started, right?
Mm-hmm, mm-hmm.
To maximize response. And then we also have our DHEA and cortisol here on this page. And what I like to point out, the free cortisol, that's really what's tissue active at various points during the day, but it reflects only around 1 to 2, up to 5, depending on the study, 1 to 5% of circulating cortisol at any given time. The reason I really like looking at urine is you also get metabolized cortisol, which to be a metabolite means cortisol had to have been made, created, and dumped right out of the body. So metabolized cortisol gives us roughly 90% of what had been synthesized and utilized on that day of testing. And we like to compare them. Do they tell us the same story, or do they tell us that there's a picture of maybe over metabolism or under metabolism? And in your case, you're right at the low end, right? Your gas gauge is on empty almost with your free cortisol. So you're really struggling to kick out cortisol when you need it, especially that second point there, that B, that morning rise. We want that to triple from your baseline or more, right? We want a really strong surge of cortisol in the morning. That's stimulating so many parts of our body, including our brain, to really stay focused and be energized for the day. You can have higher cortisol any other time of day. If you're not getting that morning rise, you're not going to feel energized, right? And so that really, you don't go up, you go down.
Right, right. That's the tired and wired or tired.
Yeah, exactly. And you have the classic wired but tired pattern because you then go up at night, a time when cortisol really should be at its lowest. You're kicking up a little, which tells me your brain's really like trying to work out and solve problems.
Yeah. And this is like this, this is what is a PTSD image, right? This is that cortisol is being suppressed, that chronic cortisol that's been pushed out for trauma or chronic everyday stress or post-traumatic stress. That's when the brain has said, okay, we're going to shut you down and stop your production because you're frying us out. That's how I say
you're
it.
too much. It's too much for too long. Yep.
Too much for too long. And so explain the again, the metabolite. Actually, I'll go to the other image on metabolized cortisol versus cortisol. Let me show you that. We'll go down to this image of testing metabolized versus cortisol, because that is confusing too. Let's see. Okay, here we go. More cortisol metabolites.
Yes. Yeah, so you do have slightly more on the metabolism spectrum, which tells me that you burn through your cortisol a little more rapidly. So you're making it. We know you're capable of making it because you are in a range that tells us, yeah, you generated cortisol that day. You just don't keep it active for very long, telling me there's a either intense demand or a support, like you're trying to eliminate it to protect your tissues. And we can see that you favor on that little fan dial there. Metabolites are going to be a combination of breakdown. So it's the tetrahydrocortisol and tetrahydrocortisone, which are various end products of that cortisol as it's processed through the liver and a little through adipose as well, to end up in urine. And when you're favoring more on the cortisol side, you're inflamed. Your body's like, we're going to burn through every little bit we can because we're still in this acute stress state. We need this. We're generating it. We don't generate enough to sustain us. We're not getting the surges we need because our signaling, right, our stress response has been augmented, either from, like, you do see this with like a PTSD brain or just chronic stress over long periods of time where the body's like, we need to make you calm down, right? But the tissues are like, no, we're going to burn through this. We're putting out fires still.
Mm-hmm, mm-hmm.
And that can have negative impact to adipose response, because that can trigger like a leptin resistance where your body's like, we need to store, we're in hibernation mode, we're preparing, right? And we need to survive whatever trauma we are going to be exposed to here. So it's like protection. But it also can create more of a glucose dysregulation with the liver. So you can get more gluconeogenesis triggering from that excess active cortisol being pulled through. And that over time can lead to more insulin resistance and even fatty liver disease. So it's one that we
Insulin
just watch.
resistance, leptin resistance, that consequence, increasing fat storage. But the fact that what about if you see a situation where metabolized cortisol is low and your cortisol is low?
Both are low. That's telling us the same story, right? That's agreement saying there's just not a lot of hormone being produced at all. The adrenals are really in a suppressed state.
Okay.
And then you can also see where there's really high free cortisol and low metabolites. And that tends to be more what we would call like a classic hypothyroid presentation, because thyroid is necessary for metabolism of cortisol. If we don't have enough free T3 specifically in the liver, we won't process out that cortisol. And so you can actually start to see.
So you won't go from the metabolized cortisol to the free cortisol.
Well, you won't convert free to metabolized.
You won't convert free cortisol to metabolized cortisol.
With
so you'll have low both, or high cortisol, low metabolized cortisol. Wait, explain that again.
High free. Yeah. I know, it's like I'm like making my air signals. You'll have higher free cortisol because you've made it. You've generated the cortisol. But when it hits the liver for processing out of the body, if you don't have enough free T3 present, it can't process out fully. So then it just remains in circulation. So you're ending up getting more and more free cortisol at key points throughout the day, but not processing it out as quickly. And that results in lower metabolites.
Okay, yeah, so this is a better one. This is a couple years later. And this is really working on that cortisol pattern, really working on the stress response. And we seem to get some recovery here. So when we look at this and we say, okay, what would indicate like thyroid dysfunction here?
So this is where you see that metabolized ratio at the lower end. So you can see that 2475 there on its dial.
Oh yeah, here. Okay.
Yeah. And it's being that metabolite ratio being low where your free cortisol is coming back. So we know your signaling is coming back. Your brain's starting to communicate more appropriately, more efficiently, or as it should. Your adrenal response is coming up a little bit more. But now you're holding on to it, right? You're struggling to clear it out at the same rate that you're producing it. And so that can be a hypothyroid. That can be liver as well, just kind of sluggish liver clearance. And the other factor here is that as you're bringing in restoration to the HPA response, to the free cortisol response, the overall adrenal kind of reserve could be going down a little post or like prior to building back up. Often you're going to be feeling better here because the HPA axis is responding appropriately, but there may be some room to really support more like nutrients for that final adrenal restoration and for liver support.
So that's all liver detoxification and support like B vitamins, vitamin C.
Mm-hmm.
What herbals? You have a specialty in herbal medicine. What
Yeah.
herbals also help? I know maca. I'm big on that.
Yeah, maca is a wonderful restorative, topical restorative. Yeah, it's great because it's also working on your sex hormone response as well. It won't directly elevate the sex hormones, but it will improve communication, which can secondarily improve. And it's just, yeah, such a great adaptogen. But
Yes.
other adaptogens, so when we're trying to rebuild, I think about, well, it depends on kind of the patient as well. But in that state, I would think more along the lines of something like rhodiola. Rhodiola is a great way to kind of give more stimulation, more stamina. Schisandras in that same vein. These are actually more on the Chinese medicine side, but also very warming. They often, like historically, like Shishandra is given for like vitality before going into battle, right? So it's that like
Like
stamina and
maca.
vigor. Yes,
Yeah.
so like maca, absolutely. So I love those when we're trying to like bolster and build back up that energy and vitality. I do like ashwagandha. It has more of a calming effect. So for your pattern or that, you know, kind of that pattern that you demonstrated or shared, we're not going to necessarily be inclined to use as much on the ashwagandha side unless you are under a lot of stress, because that could be a little too calming for you. It does improve metabolism of cortisol, however, so you could see more of a balance or restoration there as well. I also really like in those kind of chronic stress states to give nootropics. So working on the hypothalamic activity, and those are going to be herbs like bacopa. And that's one of my favorites for adrenal
Bacopa,
restoration.
okay.
It's an Ayurvedic herb, but it's really working on that response of stress to the hypothalamus and saying, hey, we can calm down now. We can bring back and get out of that cell danger response mode that we've been in and kind of restore back to recovery state and get the adrenals back online, get ACTH back to its normal, you know, knock on the adrenal door versus kind of that suppression to protect tissue. So those are kind of my go-tos on that front. You know, people will use licorice a lot for adrenal recovery. Licorice is kind of this, it will boost free cortisol. It does tend to slow metabolism a little, and in doing so, keeps more free cortisol around, so you feel more energized. But that's why you always want to pair it with other nutrients or other herbs that are going to also support the adrenal response, like that recovery response, that signaling response as well. Yeah, those are kind of the ones I tend towards.
Towards, yeah.
And
Yeah,
then I also like really focusing because we have to remember when we're thinking adrenal recovery, we're thinking hormone synthesis, we're thinking go back to cholesterol. Where is cholesterol going? Do we have adequate cholesterol? Do we have adequate mitochondrial response? So really making sure the mitochondria are in a good tip-top shape as well.
What do you like for mitochondrial resuscitation?
Yeah, so there we're looking at more amino acids. We're looking at things like acetyl L-carnitine and even just L-carnitine. We're looking at optimizing protein intake systemically. We're looking at kind of those same antioxidant supporters, so the vitamin C, vitamin E, CoQ10, really good for mitochondrial recovery and support. You can take NAD or NMN, which is an intermediate to NAD, just for like that energized cellular currency. I think of it as like the energy exchange, the money exchange in the cell. And then, you know, I'm a big fan of red light therapy as well. So
Yeah. Saunas and red light therapy. So good. So good. So much more. Okay, let's go into estrogen metabolites. Okay, so let me share this test results of hormone metabolites. So we're looking here, we say pregnenolone goes to progesterone and DHEA. And we look here on the reports when we're seeing the urinary metabolites. This is again in the urine. So we're looking at DHEAS in the urine and then the metabolism of DHEA to androstenedione. Walk us through this.
Absolutely. So DHEA has several routes of metabolism through the body, but in the adrenals. So the adrenals are going to be the primary generator of DHEA that gets circulated. The ovaries do make DHEA, but it's very controlled and regulated and converted into those parent hormones pretty quickly. So we don't circulate that as readily, but the adrenals do circulate a lot of that DHEA. So from the adrenal gland, you have to add a sulfur group to DHEA to circulate it in a stable form. So similar to our estrogen and testosterone that require chaperones and protein bound, right, to circulate in blood, that sulfur group to DHEA allows it to circulate in blood in a more stable way. So you can look at your blood and you can actually measure DHEAS. It's going to give you a different view than in urine. But just to give you the full story, right? DHEA synthesized, that sulfur group gets added, now it can circulate. However, it is inert in the sulfur form, right? It cannot bind to receptors until that sulfur group is removed. So we have two different enzymes playing a part here. We have SALT2A1 adding the sulfur group to DHEA, that's in the adrenal gland. And then we have STS, which is the sulfur transferase enzyme that's cleaving off that sulfur to allow DHEA to enter into the tissues. Once it enters into tissues, that's where it metabolizes into the androsterone or etiocalanolone. And those are your two primary intermediates of DHEA. They each do have roles, but they're also each created in various tissues. So looking at their ratios, you can see, okay, was this more anabolic? Was this utilized by tissues that are really driving that need for vigor, for vasodilation, for muscle turnover, right? Like really that it's a vitality hormone, right? It also supports the immune function, but it's really anabolic in its action, meaning it's building up tissue. And that would be your androsterone, your 5-alpha pathway. And so those are going to be tissues. 5-alpha reductase is most active in the adipose and skeletal muscle. It is active in the brain as well. So more peripheral. Etiocalanolone, 5-beta reductase, is most active in the liver. So when we're seeing more beta metabolites, we're saying, okay, this hormone was present, it was made, it was circulated to the tissues and processed primarily through the liver. And the reason for that is often to put, similar to cortisol, to put the brakes on, to say, okay, we need to rest, but also knowing that our beta metabolites improve bile synthesis, which is really fascinating. So kind of the rest and digest. Our body needs to be in that state. It's going to force it. It's going to increase beta metabolites versus running from a bear, increasing nitric oxide, increasing muscle tone, right? Acetylcholine activity, focus, stamina. That's all the alpha side. So when you're seeing those metabolites, you really get to see the story unfold of, well, what's the body using? Where is it pushing preference? Is it fairly balanced? You know, for this report, it is kind of, it's more balanced, right? You're not heavily in either green zone on either side. DHEAS is a slightly different metabolite in urine as well. It is going to be the reflection of adrenal-derived DHEA. But you have to remember that any unused DHEA also gets broken down by liver as a sulfate, that's sulfur end product. So it is also kind of the end result of any clearance of DHEA unused at the tissue level, which I also find very fascinating. But when you have that lower, so for this scenario here, we have that, I'm circling, but I don't think you can see my circle. You do have that lower DHEAS and those higher metabolites in comparison. They're not extremely off in their ratios, but just to point out an interesting pattern, when DHEAS is lower, metabolites are high, that can be inflammation and stress. It's the adrenals saying, we're not going to add as much, we're not going to circulate this as much, we're going to push it and just get it out of the tissues, right? And then at that tissue level, where is it going? And for you, again, pretty balanced. But that lower DHEAS in comparison is telling us you are making it, metabolites are appropriate for age, but you're not circulating it readily from the adrenal tissue. And that can be either suppressed SALT2A1, which inflammation suppresses, and that's often the case, or it can be upregulated STS, where you're just cleaving it off to drive it out, which again, inflammation does to push it into the tissues for breakdown and metabolism. Does that make sense?
Yeah, no, so much information. It's like, okay, this is telling us something. It helps us to take it into context. And in this image, in this time was on oral troche hormones, testosterone, estrogen. So you can see these high levels of testosterone and estrogen, but not to be alarmed because we know we have them orally.
Yeah, they're bound to saliva and then getting conjugated in the gut. We don't know what fraction you actually absorbed. What's interesting though is you can see your metabolites of estrogen there. So if you look at the actual estrogen values, they're on the lower end. And that tells me that you're not getting a lot of receptor response from that estrogen. It's in the tissues, it was present, but it's not getting pulled into the tissue at the same rate. So that is an interesting pattern with the
So this
sublinguals.
means wake up the receptors. Make
Yeah.
sure your thyroid's optimized, iodine optimization, vitamin D optimization. What else?
Optimizing those CYP enzymes and that response with cruciferous vegetables, rosemary, turmeric, all of these great antioxidants and nutrients that are going to help increase the expression of CYP1A1 to really help pull in and utilize that estrogen and break it down efficiently. So it's not just stuck in tissues. Yeah. And then your methyl activity is on the lower end too. And
Oh,
that's your
no.
phase 2 detox. So one way to think about estrogen, really, when you're looking at the parent, those estrogen, estrone, estradiol, and then estriol is actually a phase 1 intermediate, but I would call estrogen, estradiol, and estrone our primary estrogens, our parent estrogens. We have to break them down, right? And I think about this as sweeping estrogen into little piles. So like the lawn green arrow is going into our favorable pathway. That's the 2-hydroxyestrogen. And that is a really readily methylated. It just hangs out and waits for those methyl groups to add to it and then gets cleared out of the body. So we like that one. The 2-hydroxy tends to be the favorable metabolite of estrogen. I'll throw out the caveat though, that if you're not methylating rapidly enough, 4-hydroxy is the one that we get concerned about because of those quinones, but they're both catechol estrogens. So 2-hydroxy can also form quinones. They just form more stable quinones that are readily bound by glutathione and broken into water pretty quickly. So again, they're not as scary and intermediate, but they can become a quinone, which can become oxidative stress to the tissue as well. But we're kind of breaking them down into little piles. I think, the long green arrow, the benign, kind of the stable pile is like the recycling. Like it's going to get to become a problem if you built up a lot of it, right? But most of the time you can have a recycling bin in the corner of your kitchen, and it's not going to, outside of being an eyesore, it's not going to cause a lot of issues, right, in the kitchen. Versus, the little blue arrow at the other top end is the 16-hydroxy. And I think about that as general refuse. It's just your garbage bin, but that is going to gather, it's going to be stinky and gather flies over time if we don't get that out if it builds up and we don't get it out on a regular basis. But we can leave it around for about a day, and then take it out at the end of the day. Whereas the 4-hydroxy is the 1B1, that red arrow, like red for, I always think CYP1B1, B for bad, right? It's like the bad path. But that 1B1 pathway, that 4-hydroxy is kind of like your compost bin. And compost bins are very small for a reason. You want to take them out pretty regularly or they get moldy and stinky and gather pestilence of all types pretty quick, right? So we really want to get that out. Now, phase 2 is the process of getting them out. So it's the garbage bags. And for the green and red arrows, the garbage bag is a methyl donor. And it's a methyl donor donated by COMT, which is catecholamine O-methyltransferase. And you can see its name over that little arrow to the left there. And ideal circumstances, we want about half of 2-hydroxy to methylate over into 2-methoxy. That would be good kinetics of that path, of that enzyme. And that would mean you have ample garbage bags. Your ratio on this report is a little on the lower end. It's not terrible. It's not in the far left range, but you are less than half. And so there could be some room for just improving methyl response. But the other piece of this puzzle is those methyl groups then have to be loaded onto a dump truck and taken to phase 3, which is the gut, right? And so for final conjugation, we have to take them to the dump, quite literally, to the colon. And that's where I like to call it the estrobolome, little rats, right? So the estrobolome is a family of bacteria in the intestines that generates an enzyme called beta-glucuronidase. And beta-glucuronidase, anytime you hear that ACE, it means it's going to cut through something. It takes a glucuronide molecule off of our estrogen and allows it to be active again and circulate back into being in our body, right? It has to hit the liver all over. It hits those cell receptors all over. It has to be processed all over again. So that can lead to estrogen excess, and that can compound any circulating parent estrogens that we're seeing. So in this type of pattern, I think there is some compounding with the sublingual hormone, but you may also want to make sure that you're really working on your gut and not recirculating any hormone unnecessarily.
And so
Always work
that's checking
backwards.
that beta glucuronidase enzyme in a functional stool analysis.
Stool. Yeah.
Are there other ways we can check beta glucuronidase?
That's the only way I know.
Yeah. Yeah. And it's not part of this panel.
It is not. No. This panel does check another organic acid.
Indican.
So there's indican, yeah, which is protein putrefaction, which can be a result of dysbiosis in the gut. So when that's higher, you want to work on the gut for sure.
Yeah. And when this 4OH is in the, it's in the higher than the purple postmenopausal range, in that green range, it's still a concern, however.
It can be, especially so when 4-hydroxy is higher than we'd like, when it's starting to get either percent wise in that pie chart. If it gets above, I like to keep it under 10%. It's really where we see the best health outcomes. But if it gets above that 10% range, or it's frankly above the 80th percentile of its dial, so it's in the upper range of its gas gauge, you want to look at methylation. Are they methylating? If they're not, that's a red flag. The other thing you want to look at is 8-hydroxydeoxyguanosine, and that's one of the organic acids at the back of the report, the last page. That is a measure, yeah, the very last one there. Oh, and you can see your indican is high.
Yeah.
Yeah. So definitely work on your gut.
Yeah.
And again, you
Always.
always want to
And
work
this is a couple
in
years ago
reverse.
too, but yeah, it's a constant process.
Yeah, absolutely. And gut inflammation will stress out your adrenals as well, just adding further stress to those adrenal recovery. But that 8-OHDG, that's the guanine base pair of DNA. So it is the most unstable base pair of the four. And what happens is when you get a lot of oxidized activity, so a lot of oxidative stressors, quinones included, they're going to create your DNA will flag them. It'll put these little hydroxyl groups on to say, hey, we're damaged, right? The higher that value is, the more damage, the more little flags there are on your DNA, meaning the more oxidative stress your body is having to clean up right now. So we don't want that high because that means that there's a lot of DNA damage. And then the other marker would be
But what do you
pyroglutamate.
consider, like, what's a red flag on this oxidative, the 8-hydroxy 2-deoxyguanosine? I'm like, I need you to pronounce all these for me, but the 8-OHDG. So where would that be concerned? Is it greater than 5, or what do
8
you
is kind
call
of
a
my
red flag?
flag, which is the 80th percentile. Yeah, we want to keep it for a healthy individual. I like to see it under 4.8. For an individual with a history of cancer, I track it and compare it to itself. I never want it to get more than double, and really more than like about a 20th percentile above where it's at, kind of in a normal state, right? So we always want to compare if they're in recovery, they're in remission, and they're 8-OHDG, for example, like if this were someone with a history of cancer and they were at 2.2, and then we came back and tested them in a year and they had jumped up to 3.2, that's a concern, right? I'm like, even though it's in range, that's telling me there's more oxidative stress that we may want to be careful about and monitor closely. Especially in relationship to the 4-hydroxy and then the pyroglutamate, which is a marker of glutathione, which if it's too low or too high can be an indication that glutathione synthesis is not as robust as it should be. And remember, glutathione is the one that will come in and really remove any of those quinones in excess. And it's the NQL1 that's supporting the DNA repair. So those are kind of big circle, full circle of what we look at.
To go through this and talk about, yeah. And so when we think of oxidative stress, right? Like that is something that we have to be so concerned about and worried about. And we really want to get these oxidative stress markers down. And so everything we do with our antioxidants, et cetera, to help support decreasing oxidative stress is key in this case. So what would you use here for oxidative stress if this was elevated? What are the typical supplements that you recommend?
Well, number one, it's always figuring out what are the drivers of that oxidative burden. So making sure blood sugars are balanced, making sure gut is optimal, because 60% of our immune regulation or more, depending on the study, really is controlled by gut. So really focusing on gut. And then there's a few parameters here. So your MMA, that methylmalonic acid, is an intermediate of B12 metabolism. And that's telling me that you may be a little B12 deficient when it's high. So it's inverse, right? The better the B12, the lower the MMA, and vice versa. You have poor methyl activity as well, kind of borderline, which is also a B12 folate kind of dependent cycle, as well as magnesium and B6. So I'd really want to maximize for you, or for this report anyway, more on the B vitamin side to restore that cellular function to all the kind of precursors to metabolism and to these enzymes working optimally. And QO1 again is basically the enzyme that's going to turn on catalase glutathione. It's going to upregulate some of our other antioxidant cofactors and NRF2 promotion. We can also consume foods that increase NRF2. And I bring up NRF2 because this is a little key enzyme that's located in all of our cells, but it's maintained and kind of regulated by this little keep protein. So they like stay together. So it's not always on, but we want to release it when we need it, right? And its NRF2's primary role is to really increase that expression of catalase that's repairing DNA, improve glutathione synthesis and recovery and utilization by the tissues, and increase SOD, which is superoxide dismutase, which is another free radical scavenger, a really like profound neutralizer of those oxidative stressors at the tissue level. So foods that are going to increase that enzyme expression that would be used to protect cells from oxidative stress are going to be things like broccoli sprouts, really sprouts in general, but broccoli sprouts are great because they're rich in a cofactor or an enzyme called sulforaphane. Sulforaphane is a NRF2 activator. You can also, eat turmeric, pomegranate, green tea. These are all great antioxidants that you can consume on a regular basis in your diet. Maximizing proteins, maximizing fiber, also a great way just to restore balance and improve like overall detox and clearance so we can get those intermediates out so they don't damage our DNA, right? Again, vitamin C, vitamin E, CoQ10, broken record, but those are all like the ones that are protecting. They protect our mitochondria, but they are free radical scavengers as well. They are potent antioxidants. It's kind of my go-tos.
Yeah, no, I appreciate that. Anything else on here, like specifically to look at or to be concerned about or pay attention to low end of range, above range? I know the indican for the gut, but when we look at dopamine metabolites, we see dopamine metabolites, but what gives us an indication for serotonin here? Is there anything that gives us a serotonin?
We don't have 5-HIAA on here. That is an organic acid. That is a
Yeah.
serotonin marker. It's just really unstable and heavily influenced by the gut. And you have to avoid so many foods that convert to it to get accurate readings
Mm.
that they just decided to take it off of the touch panel because it was really hard to capture a good reading, right? Because you'd have to avoid like bananas and like citrus and most carbs that can like most grains that can convert into that same intermediate that would falsely elevate it. So it's a tricky one, but kynurenate can be an intermediate of serotonin as well. So you think about the serotonin chain with tryptophan. Tryptophan is our precursor to serotonin, and it can either convert to serotonin and then that further helps us generate melatonin, or it can go down the kynurenate pathway. And kynurenate can be neuroprotective in small amounts, but can become neurostimulating in high amounts, and then breaks down into the quinolinate, which is their third from
The bottom, yeah.
the bottom on that report. And that one is neurotoxic. And so we always like to look at those ratios and see, okay, are they pushing? Because especially in our postmenopausal years, there's this enzyme called DIO that requires estrogen for activity and support and will upregulate when estrogen is low, converting more tryptophan to kynurenate, which then can push into quinolinate, which can become neurotoxic and can lead to the brain fog and anxiety and kind of disturbed or disrupted sleep cycles even that we see in those postmenopausal years. So it is one that I like to watch, especially when estrogen starts to decline. It's actually a Goldilocks. It's like too high or too low, right? It can augment that enzyme. But really keeping a close eye on kynurenate and then how it's being processed, and is quinolinic acid or quinolinate also going up? That's a problem. If not, then it's being metabolized correctly. But kind of an
So
indirect.
many so many ratios, right? And the
Yeah.
glutathione marker, like we think of this with it's too high or too low, it's deficient in glutathione, but to support 4-hydroxyestrone detoxification, we want to support glutathione too.
Absolutely. Yeah, especially if we're seeing that pyroglutamate either too high or too low.
So with
Yeah.
NAC or liposomal
Yeah.
glutathione?
Liposomal glutathione can be great. It can be readily oxidized in the body, so its bioavailability is a little more limited. You do have to take it more regularly to get benefit. NAC is a precursor. So remember, glutathione is made of 3 amino acids. So it's made of cysteine, glutamate. Wow, this is my brain in the afternoon.
Mm. I don't remember,
This
so
used to
that's
be
good.
my, let's see, glutathione, cysteine, glutamate, and
Sometimes.
it'll come to me. It's down the same cystathione pathway as converts over to taurine. Creatine is in there too. Wow, I'm so sorry. That
No,
just
no,
like
that's okay.
poofed
Hey,
out.
but
That was
anyway, NAC is a good
NAC
precursor
is a
to glutathione.
precursor, and it is a rate-limiting amino acid that's necessary for that glutathione synthesis.
Yeah, and is there anything that you need with NAC to convert to glutathione or just metabolizes that way?
So B6 is actually a cofactor that's necessary for conversion. B6 is necessary in a conversion of a lot of different
Yeah.
enzymatic pathways in detox. So I just say, B6 is a good one. But yeah, you do want, and vitamin C. Vitamin C is critical for both absorption, but also synthesis.
So we think about, okay, wait, postmenopausally looking at hormonal therapy and on or off hormones, but waking up those hormone receptors, right?
Yeah.
We want to wake up those hormone receptors. When we think about, okay, detoxification is key, decreasing oxidative stress, adequate amounts of vitamin D, vitamin C, our vitamins E, the delta and gamma tocotrienols. Those are important for the receptor site. Iodine, bumping out chlorine, fluorine, and bromine. So cleaning up those detox pathways, that's critical to waking up the receptors. And anything else, because we think about like DIM and calcium D-glucarate. When do we want to use DIM? DIM from broccoli, broccoli seed extract or broccoli sulforaphanes. We can look at that, but DIM versus I3C and calcium D-glucarate. When, especially in the case of when we're seeing this estrogen dominance issue. When do
With
we want to
estrogen,
take it? When don't we want to take it?
absolutely. That's a great question. And I think so there are differences between I3C and DIM that I like to point out. I3C is indole 3 carbonyl, and that is that becomes DIM, diindolylmethane, in the gut, but it requires stomach acid. So I don't like to even give I3C because most of
I don't
us
either.
don't have good like stomach acid. Yeah. So diindolylmethane is really my preferred. When we want to use it though, it's going to be a phase 1 promoter. So it's really increasing expression of the CYP1A1 pathway primarily. Uniquely, there are some variants to CYP1B1 that can actually get promoted with DIM. So you have to be a little careful with its utilization, but it's going to focus, it really does elevate that 2-hydroxy, which is that intermediate that we tend to see as most stable. But we don't want to give that if they're not methylating, right? We don't want to build up our garbage pile if we don't have enough garbage bags to deal with it. And we definitely don't want to build it up if the rat population in the colon is overpopulated. So we really want to make sure that beta glucuronidase is controlled and regulated with estrogen dominance, especially. And then we work backwards, right? So we make sure that we're controlling the rats, that we're regulating phase 2, which is sulfation and that methylation pathway. And then if those are working well, now we want to feed that CYP1A1 and really boost clearance of estrogen into that 2-hydroxy form. The thing with with DIM is it will increase clearance, right? So it will kind of turn the volume up on CYP1A1, which means it's going to pull out more estrogen. So it will lower estrogen in circulation. But for some women, that can make them feel a lot worse if they're not methylating and if their gut is not corrected first. So again, always work in reverse order. But calcium D-glucarate, its primary action is to neutralize the rats, right? to neutralize beta glucuronidase, to prevent that from cleaving off that glucuronide side chain so that we're not recirculating estrogens. So that can really be profound to help lower estrogen when you see that dominant state, especially if you know they've got an imbalance with their gut, with either dysbiosis or they just symptomatically, they're chronically constipated. If you're not pooping every day, you would likely have an issue with your estrobolome.
Mhm, mhm. So is
But
there anyone we wouldn't use calcium D-glucarate in?
You don't want to use calcium D-glucarate too much or too high a dose in your postmenopausal women because you do want a little estrobolome response in our postmenopausal years. It is helping to recirculate what little estrogen we have, unless they're on BHRT. If they're bringing in exogenous or outside estrogen into their body, and we're trying to regulate it and we're struggling to get them in the right balance, and we think, yeah, it's this overactive estrobolome that might be playing a role, then we can add it in. But if their gut's not the problem and we want to maximize their BHRT or just maximize their own creation of estrogen in circulation, I wouldn't use it in that situation.
Yeah. And anything else to wake up those receptor sites?
It really is about reducing that oxidative stress. I think
Mhm.
movement is key, reducing stress,
Red light
making sure that
therapy.
we're, yeah, red light, hydrotherapy, so cold therapies, getting brisk cold water can really help with that receptor response and return to normalcy of our nervous system. Um, so I think really through lifestyle, there can be a lot that can be corrected. We don't want to just supplement away our symptoms, you know,
That's right.
uh, but
That's
really
right.
focusing
That's
on this.
so true. Okay, this has been so science-based and in the weeds and informative and helpful. And again, looking at all these issues, I've been looking at hundreds of Dutch tests for my Magic Menopause group too, and all different kinds of patterns and pathways. But I would tell you, like this concept of DIM, I had a client optimized on her estrogen, on her hormones, optimized on her hormones, doing great, feeling great. Then all of a sudden she's like, now I'm having hot flashes. I need to go up to, 1.5 patch a day. So 1.5 or 0.15 estrogen patch. I'm like, wait, that's really high. What's going on here? So what supplements are you taking? She said she added on DIM and calcium D-glucarate based on her genetic profile. I'm like, okay, but let's look. Your metabolites are great. Your gut's great. Let's stop the DIM and see what happens to your hot flashes. Immediately they went away. So I think that's really important to understand, even with hormonal therapy, that we are going to we can alter it with supplementation and decrease the use of your good hormones based on that supplementation. So when you've looked at, like, when you see urinary hormone metabolites and you say, okay, there's that red flag that we really need to optimize uh, your estrogen detoxification pathways. Is that, the elevated 16 hydroxy, the elevated 4 hydroxy, the low methylation issue, and that dial, when we look at those ratios and we see those are bumping up greater than 10% each, that pretty much when we're going to say, okay, now we need to be concerned. And in working with, is that pretty much right?
Yeah, yeah. I think when you start to see the imbalance of that shift away from 2 hydroxy preference, and especially when it's in tandem with that low methyl index or that low methyl clearance, yeah, that's when we're like, oh, okay, we're going to need to do some work here to support estrogen detox.
And different ways to methylate, right? We have methylated folate, we have SAMe, we have TMG,
And I
different.
think with estrogen metabolism and methylation, it's very different than what we would think for methylating neurotransmitters or methylating through, our for DNA repair, or the on-off switch of the methyl, flags on CPG islands within DNA, and that can those epigenetic programs. Estrogen detox is COMT dependent. So catecholamine, O-methyltransferase. So that catecholamine, it's breaking down or it's methylating all catechol, but including the catechol estrogens, the 2 and the 4. I'm not saying 16 because that's actually sulfated and glucuronidated. That goes through a different path. But when we're looking at the catecholamine O-methyltransferase, it has specific requirements for expression. So magnesium, rate limiting cofactor, right? So we always want to focus on magnesium when we see low methyl of estrogens. I don't directly go to folate and B12 per se, unless I'm seeing other reasons to bring that in. But magnesium, B6, and then trimethylglycine. Those are really the big ones for that enzyme to work optimally and to get the right methyl response. And then SAMe is the master methyl donor. So that is what gets bound to COMT and circulated to the catechols to transfer and reduce down into phase 2, to transform those catechols further into their methoxy forms.
Yeah. I always forget about SAMe, but what foods increase SAMe? Do we know?
So really it's amino acids. So it's going to be
Amino
protein.
acids. Yeah,
Yeah.
protein. Need more
So
protein.
methionine. Methionines are a big one. Methionine and serine. So lean proteins.
Yep. Yep. Okay. Well, thank you so much. I know I can talk to you forever on this and go deeper in the weeds. And this has been so helpful. And I think, again, it just really emphasizes that there are many ways to test our hormones and look at them, and they each tell us something differently. I feel like the safety and efficacy of looking at our hormone metabolites and taking them into context tell us a lot about our physiology and our epigenetics and can help guide us in therapeutic therapies, especially if there's fear of breast cancer, family history. We worry about those things, and looking at this and feeling empowered and making sure our metabolites are okay. There are other reasons to get breast cancer, but we can safely, manage and monitor hormone therapy in these individuals by looking at these testings. Would you agree?
I would absolutely 100% agree.
Tell
Yes.
our audience how to connect with you, Liz.
So I am currently the CMO of EndoAxis. We are a company dedicated to helping providers understand the Dutch test in its entirety. So going into the weeds even further on these reports that we saw as an example today, you can reach me at liz@endoaxis.com, and you
Liz
can
at
always check us out at
endoaxis.com. And endoaxis.com is the website as well. Liz at endoaxis.com. Thank you for so generously sharing your information and wisdom and all you're doing for women and men in balancing their hormones, increasing their health optimization and longevity. I appreciate you and all your work. I would love to talk more about endoaxis in another episode and all the things that you're doing there with the different categories. So thank you so much for being here.
Absolutely. Thank you so much. It was an honor to be here on the podcast today.
Oh my gosh, lovely, lovely. So for our audience, this is one of the reasons I like to use the Dutch test and look at it in depth. And it changes over time, as you can see. And depending on what we're doing to our body, how we're interacting with our environment, and as Liz really emphasized, look, the lifestyle changes that you make, sunlight, nutrition, getting outside, grounding, all of these things impact our health better than anything we can write on a prescription pad or put into a bottle. So we have to take that into consideration. That always comes first. Now, with that said, there are ways to optimize our hormones, support our adrenals, support our estrogen metabolites, and support our overall hormonal health and balance so that we can age really, really gracefully and powerfully for our entire life. So thank you all for being here on the Girlfriend Doctor Show. I know you have questions. Email them in to team@drannakabeca.com, team@drannakabeca.com. Let me know what questions come up for you or what's your next right step. And please share this episode, like and subscribe on my YouTube channel. And I'm very grateful for your reviews. Your 5-star reviews help us rank in the charts and reach more people. Till next time, this is the Girlfriend Doctor. God bless.
Thanks for watching another episode of the Girlfriend Doctor podcast. Check out all the links below for more.